Welcome to the latest edition of the Mind-Gut Conversation. Today, I had the pleasure to talk to Dr. Elena Verdu, who is professor in the Division of Gastroenterology, Department of Medicine at McMaster University, Hamilton, Ontario, and a member of the Farncombe Family Digestive Health Research Institute. She is also the director of the Mouse Microbiota Unit and holds the Canada Chair in Nutrition, Inflammation, and Microbiota. Dr. Verdu is one of the leading international authorities on the topic of gluten-related disorders, and her group studies host microbial and dietary interactions in the context of celiac disease and gluten sensitivity. Her group has been working on the preclinical development of several adjuvant therapies to a gluten-free diet. Welcome to the show, Dr. Verdu.
Thank you very much, Emergence.
You've been working on a topic that has received a lot of attention from the media and the public in the last few years, and I'm looking forward to learn from you what is evidence-based and what has simply been hyped up in the lay media on this topic. Let's start with the non-controversial part of the interview, namely celiac disease. So let me ask you a few questions on this topic. Has celiac disease increased in the last 30 years? And if yes, what do you think the reasons are?
So the short answer is yes. The prevalence has increased, but there is no doubt that we also diagnose celiac disease better, because in the late 90s, the discovery of tissue transglutaminase as the autoantigen in celiac disease made it possible that now we have specific serological tests to diagnose celiac disease. So it's a combination of better awareness, better diagnosis, and also increase in prevalence. And we know there is increase in prevalence because there have been studies that have been done using that specific serology in sera that was bunked in and frozen for 40 years. And that was compared using the same test with a cohort of individuals today. And we see a fourfold increase in true prevalence.
Is this increase seen all over the world, or is it seen mainly in the developed world?
So this is an excellent question. Actually, we are seeing now an emergence of celiac disease all over the world. So in areas of the world that we thought were not affected by celiac disease. So for example, in Africa, in South Asia, India, and some other Asian countries, they are showing that there is the same seroprevalence of around 1% in all these countries, including in the Americas and in South America.
So that means something is going on similar to the increase in other autoimmune diseases, for example, that started with increase in prevalence in developed countries and now is the same phenomenon is happening in the rest of the world. Is that correct?
Right. You make a very good observation. Actually, the prevalence of celiac disease has been increasing in parallel with other autoimmune disorders like type 1 diabetes. And actually, celiac disease associates, for example, with type 1 diabetes, also with autoimmune thyroiditis and so on. So you're right in pointing at this parallel increase in prevalence.
So there's, with this kind of pattern, you almost suspecting there's something environmentally going on that could explain these changes, and lifestyle factors, including diet and other things probably are on top of the list. What factors do you think are most likely responsible, particularly in relationship to our diet?
Right, so we have long suspected that there is an additional environmental factor in celiac disease. So we know that the main environmental trigger is gluten, right? This complex group of proteins in wheat, rye, and barley. But genes, together with this environmental trigger, are not sufficient for the development of celiac disease. So to answer your question, we have long suspected that, for example, changes in the way we introduce gluten to the diet in early childhood, the presence or not of breastfeeding, could be environmental modifiers. Now, we have already the answers from those large cohort studies, and unfortunately, the results have been quite disappointing in that they are not showing us that the way we introduce gluten to the diet in an at-risk kid in early life does not affect profoundly the development of celiac disease. And breastfeeding, although it's very positive for many other things, it does not seem to also protect from the development of celiac disease in these kids that are at risk, at genetic risk. And so the emergence of microbial factors in parallel, of what you were mentioning with other autoimmune disorders has emerged in the last 10, 15 years. And here we have a combination of potential pathogen effects, so viral or bacterial infections, which through a number of mechanisms could favor the development of a pro-inflammatory environment that will promote the autoimmune development and the abnormal reaction, T-cell reactions to gluten. Or it could be also long-term changes in your microbiome due to, for example, these infection episodes, very similar to what happens perhaps with post-infective IBS or post-infective IBD.
I mean, talking about the microbiome, could it be that the progressive decline in diversity and abundance of the microbiome, which has been studied well in Western countries, that somehow plays a role, that any time you have a decrease in diversity of an ecosystem, it becomes more vulnerable and less resilient? Is it conceivable that this general trend of decreasing diversity plays a role?
I think it's more complex than that. It goes beyond diversity. Microbiologists, they don't agree too much in what a decrease in diversity is. So in the context of celiac disease, at least the work that we have been doing, what we see is that the important trigger here is gluten. And it is key to understand that this is a protein with difficult digestion. It is based on the chemical structure of the gluten proteins, where our enzymes are unable to digest properly these peptides. Now, if you don't have the genetic predisposition, nothing will happen. Those peptides are going to be excreted and you will have no reactions. But in those with genetic predisposition, these are the peptides that are going to be absorbed in the proximal small intestine and are going to induce the pro-inflammatory response. So what we have found is that the bacteria that you have in your small intestine, certain opportunistic pathogens with certain enzymatic activity, will significantly contribute to the digestion and modification of those peptides. And that's going to contribute to the further absorption of these peptides and the triggering of immune responses. So we have to understand that in the small intestine, we have a microbiome that will participate in the metabolism of these immunogenic proteins, and in that manner, it could affect or tip the balance towards becoming celiac if you have the genetic predisposition.
It would almost seem to me more plausible that some mechanism like the one you just explained is now more common amongst people around the world, rather than, for example, the amount or the type of gluten in our food is increasing worldwide.
Yes, so you have a point. Actually, this is, if you have, for example, an infection, a viral infection, or several viral infections, you can have then superinfections with bacterial pathogens, and you can modify long-term your small intestinal microbiome in a way that does not effectively metabolizes gluten. And in fact, what we saw is that in patients with celiac disease, we also had a decrease in the lactobacillus in the small intestine, which can detoxify certain peptides. Certain lactobacillus could detoxify them. So it is more the imbalance rather than perhaps the low diversity. Remember, the proximal small intestine is a low diversity, low yield sample in terms of microbiome. But it is more this imbalance that could be caused by these changes in habits, long-term habits, as you mentioned, and in parallel with other diseases. So that's a very reasonable hypothesis.
Okay. Slightly going away from the causes of this increase in gluten sensitivity in celiac disease, what percentage of people that have celiac disease based on positive blood tests or mucosal biopsy actually have symptoms? In other words, is there a significant proportion of the population that has the disease but doesn't even know about it because they have no symptoms?
So if you take the global population, and we would do a screening, a serological screening in the global population, so the majority of those patients are not going to have symptoms or signs of celiac disease. And when we say symptoms, it does not necessarily mean gastrointestinal symptoms. It could be other types of signs of celiac disease, like, for example, anemia, which the gastroenterologist may or may not see. Now, if we take the population of diagnosed celiacs and we determine how many of those are symptomatic or not, so up to 30% of celiacs, diagnosed celiacs, could be asymptomatic or minimally symptomatic.
So this is really a much bigger problem than the clinical impression would indicate.
Well, it certainly has shifted our understanding of celiac disease.
Let me ask you something. I see a lot of patients that would in my clinic where the topic of gluten, celiac disease, non-celiac gluten sensitivity comes up, and I'd like to get your opinion on a particular patient I recently saw. So this individual never had any gastrointestinal symptoms, ate a completely normal diet until he had a routine blood test done for celiac disease. Not sure why that was done. And he was told by his physician to go on a strict gluten-free diet, which he did. When he was traveling in Europe, he wasn't able to stay on this strict diet for 2 days and became violently ill. He never had that. He became so sensitized by this experience that he's now paranoid to travel anywhere out of fear that he doesn't have access to gluten-free food and that such an episode may recur. Have you heard of such patients, and what would be the mechanism of this seemingly sudden sensitization to gluten?
So I'm assuming really that this patient was properly diagnosed with celiac disease, so that that was a specific TG2 test or anti-individual antibody, and that it was confirmed hopefully with biopsy. So if the patient was celiac, it is not, as we said we were just saying, it is not uncommon that the patient could be asymptomatic or minimally symptomatic, or at least asymptomatic from a GI point of view. But that same patient could have had some other kind of sign that was not necessarily GI related. Now, when placed on a gluten-free diet, which is well indicated if the patient was a confirmed celiac, and he went on a trip and probably he was not following the diet properly and he was being challenged. So it is also not uncommon that patients that go onto a gluten-free diet, perhaps they respond initially, but they become symptomatic again, precisely because of this, because they continue to suffer challenges, because it's very difficult to follow 100% a gluten-free diet. Now, the interesting point in your case is that the patient became violently GI symptomatic, right?
Yes.
So it could be a shift in the presentation of the disease, but perhaps if you do a proper anamnesis, you may find that there was some other neurological or chronic fatigue symptom that did improve with a gluten-free diet. And it's just that now with these new challenges, the patient is expressing a GI symptom. Celiac disease is a chameleon. It's a clinical chameleon in terms of symptoms, and it is a multisystemic disorder. Now, the mechanisms of why celiac disease may manifest primarily with a GI presentation or a neurological presentation or skin presentation? That is a fascinating question, and we do not have exact mechanisms for that.
Okay. Now, do you want to add anything to this topic before we move on to the next topic on the topic of celiac disease? Any new insights? So I understand you're working on adjuvant therapies beyond just going on a gluten-free diet, or even instead of a gluten-free diet. Are there any novel developments that you see happening in the near future?
Right. This is probably the new frontier for celiac disease, the adjuvant therapies, for the reason that I just mentioned, that it is really difficult for a patient to stay completely gluten-free. And there is an anxiety component that is associated with constantly being afraid of contaminations, like the patient that you have just described. This is quite common. And so there is because we know so much about the pathophysiology of celiac disease, there are many groups that are developing, and also industry, that are developing targeted therapies to complement the gluten-free diet. We're not saying that patients will be able to go gluten-free, but they are going to decrease the risk of contaminations. And there are several opportunities to attack all the steps in the pathophysiology of celiac disease. There is vaccine development, there is complete detoxification by proper digestion of gluten, modification of the immune response. All these areas are being targeted currently. And there are some of these components that are already in phase 2 or in phase 3 clinical studies.
So, I mean, I guess that the fact that there's now an interest by the pharmaceutical industry in these areas because of the increased prevalence. Before, it was, certainly when I went to medical school, a pretty rare disease that seemingly nobody wanted to invest any money in drug development. But this situation clearly has changed now.
Yeah, I think you're right. And it's the combination also of better awareness and increasing prevalence, for sure, and better diagnosis. We are now in North America, since that seminal paper by Alessio Fasano and colleagues, we have put celiac disease in North America's map.
Let me ask you one more question that you mentioned, this anticipatory anxiety component. So like the patient that we just talked about a few minutes ago, this individual was clearly traumatized by the experience and developed, what we could call a conditioned fear response. How much does that play a role in patients, even if they're treated well? So, for example, let's put it in a different way. If somebody with celiac disease goes on a gluten-free diet, but they have had multiple experiences before where they got violently ill, does that fear persist in some patients, and do they still have symptoms even on a gluten-free diet, just based on a conditioned fear mechanism?
Well, that's a very, very important point in management, in the long-term management of these patients, the management of the anxiety, of the social phobia that sometimes these patients go through, and sometimes the reaction of other people to their anxiety for being gluten-free. This is really unfortunate, and sometimes in social situations, these people are mocked for having those concerns. So this is very, very important, and something that has to be addressed in terms of monitoring and also in terms of better therapies to manage these patients.
Let's move on to the topic of non-celiac gluten sensitivity, also an entity that has apparently increased dramatically. It's a multi-billion-dollar industry. There's many books to the lay public out on this topic, and it's almost now a universal, certainly in my practice, a universal phenomenon that people say they're sensitive to gluten, even though the diagnostic tests for celiac disease are negative. Do you believe this is a real disorder, given the numbers of patients that seem to be affected by it and blame all kinds of symptoms on this sensitivity? Or do you think this is sort of a mass hysteria or mass nocebo effect that people now can blame any kind of symptoms of discomfort on this mechanism?
Right. It's complicated. I mean, I would start by saying that the most important point here is if a person believes that they are sensitive to wheat or gluten-containing diet, they should first see a physician to properly rule out celiac disease. So once that is done, and we can do that quite well with a specific serology and with biopsy, then we enter in an area where there is very little evidence. There's no evidence-based medicine, strong evidence-based medicine in this area of wheat sensitivity. This said, I think there's no doubt, and you probably as a practicing physician and seeing these patients know that there are many patients that are going to come to you or to the gastroenterologist, referring that they have symptoms that can be gastrointestinal related or sometimes even neurologically, or this brain fog that many patients allude to, that are triggered when eating a wheat-containing diet. Now here we enter in a realm really of functional GI disorders. We have many problems here. We have no proper biomarkers to diagnose it. So we cannot really say how prevalent this is, only base it on the number of cases that we see in our practice. There is also a big area of concern regarding what is the specific trigger in this wheat-containing food that can lead to the generation of symptoms. And yes, it could be gluten, but it could be other proteins that are present in gluten. It could be other fractions, non-protein fractions in the wheat-containing diet. Now, how frequent this is and how many of those IBS patients truly have these food sensitivities, again, this is very difficult to say. Probably, from my point of view, this is going to be a minority of the whole IBS population, simply because IBS has, as you well know, many different triggers. And so this food-sensitive IBS will be a proportion of that global population of IBS patients. And so the challenge probably is to try to infuse a little bit of evidence in this area and try to distinguish what the components for triggering the symptoms are, and if we can predict which are the patients that are going to mainly react to restricting one component or the other.
So one question always comes to mind on this topic. Why has it become such a big problem in the last 10 years? And why is it a particular problem in North America? So every time I travel to other parts of the world, particularly Europe, I ask people, and generally my impression is that the French, the Germans, the Italians have not really reduced their intake. Individuals who have these kind of symptoms, they've not really reduced their consumption of bread in these countries. Do you think there could be something unique in North America that is underlying this? So we're not talking about celiac disease, but this non-celiac gluten sensitivity.
Well, we are becoming a little bit philosophical here, right, with this question. But it may have to do with celebrity endorsing as well of many of these diets. I mean, most of the people who are adopting this or that restrictive diet, they are doing it based on blogs that are poorly referenced or celebrity endorsements and so on, and not based on real data, on real evidence. In Europe, there has been for many years a clear understanding of what celiac disease is. And I think that we are still here in North America on this confusion between real celiac disease and then symptomatic reactions that have nothing to do with celiac disease, and that may be triggered by many factors in diet or even non-related to the diet. And so it may have to do with that, with where people are going for their information and taking advice of, of celebrity endorsed diets that sometimes can harm more than the initial symptoms that the patient had.
Yeah, I would fully agree with this. And I mean, there are currently no biomarkers to make a definitive diagnosis in contrast to celiac disease. And several controlled studies have failed to clearly identify gluten as the offending agents. I mean, there's some studies that have, but others have not shown that. So that really goes along. It leaves the question unanswered. Is this a biological issue, or is this really a perception and I would almost say a mindset that you have decided you have that sensitivity, and now any symptom that you have, be it brain fog, which very often is mentioned by patients, or digestive issues, that so now you have an explanation for these symptoms, and people can no longer say you have just IBS, or it's in your head.
Exactly. It's a combination of factors. There might be a small proportion of patients that truly react to components in wheat, and there will be even more prominent proportion of patients that believe that diet or that component is causing symptoms. So a sort of nocebo effect, as you mentioned.
Mm-hmm. There's also, you mentioned brain fog. This is an interesting phenomenon. I've heard this now from people not just on a gluten-free diet, but also on a ketogenic diet, or even on a Fodmap diet in IBS, that one of the main benefits from any one of these diets is that they no longer suffer from brain fog, and their ability to concentrate has increased dramatically. Do you have any opinions on that? I mean, again, this is one of these symptoms that are hard to pin down and are very subjective and difficult to explain as well.
It is very difficult to explain, and this is something that patients refer to you when they respond to a gluten-free diet or to a low Fodmap diet and so on. The mechanisms, I don't think that we know. Simply because we don't understand the basic mechanisms of food-induced gut dysfunction fully. So it is very difficult to understand how this affects brain fog. I mean, definitely, and you are an expert on this area, we know the gut-brain connection is important and bidirectional. And so there could be potential mechanisms for this interaction and for explaining an improvement in neurological or psychiatric symptoms, if there's truly an effect of a food component in the gut. But right now, this is really speculative. It is a fact that some of these patients respond in this way, but the mechanisms, they really remain unclear.
So in your own practice, in which patients, other than those that have diagnosed celiac disease, do you recommend a gluten-free diet?
So I don't practice in Canada. So I only run a wet lab, Emergence. The celiac, but I can tell you what is evidence-based. So if you have a diagnosis of celiac disease, you have to follow a gluten-free diet. There is no way around that. Now, with respect to those where celiac disease is ruled out, if the question is in how many of those, here in the McMaster Clinic, for example, how many of those patients go on a gluten-free diet, that depends on the patient characteristics. But what we are seeing, and this is based on some of the clinical studies that are coming out from our labs, is that some of the patients that have or refer symptoms with a wheat-containing diet and that have positive IgG anti-gliadin antibodies. So this is not a diagnosis of celiac disease. In fact, celiac disease is ruled out by negative TG2. But in those patients with positive anti-gliadin, IgG antibodies, which are not specific for celiac disease, we see that these patients tend to respond more frequently to a gluten-free diet than to other diets or to other interventions for IBS. But definitely, I can tell you that dietary restriction is not the #1 therapy or the top of the list therapy for our IBS patients.
Okay. One last question. Obviously, you don't see patients yourself. So it may be difficult to answer that, but just based on the evidence in IBS patients, so many of them avoid gluten. From a physician side, many are being recommended to go on a Fodmap diet, which seems to be now the consensus amongst gastroenterologists interested in treating in irritable bowel syndrome. What are your thoughts about the Fodmap diet? I mean, this is obviously, it's pretty clear that in many patients, symptoms get better in the short term, but it doesn't seem either practical nor healthy to keep people on such a diet for any length of time.
Yeah.
Since we know that the gut microbes will not permanently change after a course of a particular diet, but return back to their original composition, what's the benefit of such an intervention?
So there is a place for a low FODMAP diet in a subgroup of patients with IBS. And for example, if there are patients that really manifest with excessive bloating, this can be useful in the management. From what I discussed with my colleagues here, in the first place, the low FODMAP diet, definitely like any other restrictive diet, should not be a long-term diet, because as you very well and correctly mentioned, this can lead to subsequent changes in the gut microbiome that require those elements to thrive. And some of those are bifidobacteria, for example, that ferment those fibers in the colon. And that produces the fuel that is necessary for maintaining our mucosa in the colon. But there could be, a proper diet that is related, and this is a paper that Magnus Simren did published in Gut, where just the advice of reducing certain components, not necessarily a strict low FODMAP diet, reducing the sizes of meal, and when those meals are administered, not too close, for example, to going to bed and so on, that this already can help as well as a low FODMAP diet, which is very restrictive. So dietary management can help a lot in IBS patients, but perhaps it's not necessary to have a very restrictive low FODMAP diet. And we can use these common sense dietary modifications that are also going to help the patients very much.
Okay, Dr. Verdu, come to the end of this interview. Thank you very much for this very thoughtful conversation. And I wish I could refer patients to you, but I guess they will have to be content with knowing that there's somebody in the scientific field in this area that provides objective data to make it less confusing for the patient what to do and which advice to follow. So thank you very much.
Thank you for having me, Emergence.